it's a dangal, the debate, and this Mahavir Singh Fogat of Amravati is here to win the case. Okay, so I am in the traditional attire. How do I look? So this two-piece is enough. This two-piece is enough to win the case. I'll show you how. And respected Dr. Narwadkar sir will require a tie, a coat, a big bag, and 2 people to hold that bag because he is going with laparoscopy. So I am with NDVH, and in coming few slides we'll see how. So non-descent vaginal hysterectomy is popularly known as NDVH. What is hysterectomy? Is removal of uterus, whether it's pathological or whether it's a DUB case. Routes of hysterectomy we can divide only in 2. It can be a transabdominal by either of the route. It can be a laparotomy, laparoscopy or robotic, or it can be transvaginal. So how do we select the route? It's upon the patient's choice, surgical skills and disease process. Mind you, the patient's choice should be unmanipulated, and surgical skills should depend upon the patient's safety. So why do we say that vaginal is better than TLH? The time required to complete surgery is less in vaginal hysterectomy. It is also associated with better outcome when compared to with other approaches, and early ambulation and early discharge in cases of vaginal hysterectomy. So this is not by me alone, it's by the Cochrane Library 2015. And mind you, Cochrane is the most reliable and most sought after review library, and it only reviews the evidence. So it is the evidence-based medicine which is telling us this. Also, the same Cochrane Library tells us that less complication in all grades. So grades of the complication are divided into grade 1, 2, 3, 4, and 3 and 4 grade are grade 3 is when you have to take the patient back to OT to redo something which should is got complicated, and grade 4 is when the patient goes to ICU. So grade 3 and 4 complications are very, very less with vaginal. Definitely, as I told you, lesser equipment cost. See, I have got the equipments of vaginal in my pocket. With these 5 instruments, you can complete a vaginal hysterectomy. But respected Narwadkar sir will require so many things, maybe 50 of the instrument. Even if he doesn't have a cord to connect, if he forgets his cord, if he goes to operate at some place, if he forgets the cord, he cannot operate because he will not be able to visualize. Learning curve is short, even cost of the training is less. Early return to work, salpingectomy and oophorectomy can be easily done. Cost and charges. So this is the original talk was by Dr. Anil Sakhare sir from Nanded. So he has provided me, he was like the guru who gave me the Shastra and tell Vijay Bhava. So he gave me all these slides, and but the ladai to mujhe hi ladni hai. So he has sent this chart also. Hysterectomy, the charges of abdominal and vaginal are between 20 to 22, but when it comes to laparoscopy, it goes up to 35 plus anesthetist and all those things. So it is the minimum chart rate by the Nanded Obs-Gynae Society. So it's a minimum chart rate, okay? So higher we don't know what it will be. See the equipments required. Equipment, the simplicity, cost and maintenance. Okay? Complications, the port side infection after laparoscopy. Although it happens very less, it almost 3%, but it requires quite long time to heal, and it is also by Journal of Minimal Access Surgery from 2013. All these slides are evidence based. Then secondary hemorrhage is also one of the complication, is quite high in TLH as compared to vaginal hysterectomy group. This is a paper in which Dr. Sakhare sir was an author. The second author is Dr. Sakhare sir, and it got published in the journal. So he has sent me that. And again, the complications to continue. Studies shows that complication rates are almost same in both the surgeries, but as I told you, grade 3 and grade 4, it is less in vaginal group. Incidence of ureteric surgeries, ureteric injuries and bladder injuries is high in TLH group. Though meta-analysis show that overall number of complications are same, but complication of grade 3 and grade 4, I told you, that's almost double. Post-operative pain. So Croft et al. He showed that the use of energy-based vessel sealer in vaginal hysterectomy, it reduces the pain by quite a lot and also the blood loss. And there is one technique called as Purohit technique of vaginal hysterectomy, in which bipolar forceps along with saline irrigation is done post-operatively, and it has showed promising results in post-operative pain. There are some people who have done on the same day of surgery, they have discharged the patient. So it is that comfortable. When it goes uneventful, even the same day or next day morning itself, you can discharge the patient. So even that time of hospitalization is not a matter, as sir will argue, I think, afterwards. Opportunistic salpingectomy usually can be safely accomplished at the time of hysterectomy. So this is also one of the thing which we can do easily. Feasibility can be increased. Simple adnexal masses, simple ovarian cysts are no more the contraindication for vaginal hysterectomy, and it can be increased in case of fibroid more than 12 weeks. There are some techniques like core-ring, debulking and morcellation techniques which are gold standard and can be used in vaginal hysterectomy as well. Even in previous one or more cesarean sections, people have done up till 93% cases successfully, and it's published in American Journal of Obstetrics and Gynecology. Now, this is something which we need to be very aware of. Marketing rules over the evidence. See, in the last decade, 2006-2010, the use of laparoscopy has reduced, the use of vaginal has also reduced. What has got increased is use of robotic in the Western literature, okay, even in the Western world, okay. But the use of the second line, you can see the use of robotic assistance for execution of laparoscopic hysterectomy either can be abandoned. This is the evidence says it should be abandoned or it should be further evaluated, since there is lack of evidence. So I will conclude that vaginal hysterectomy is the approach of choice whenever feasible. TLH is preferable alternative to TH, mind you, TH, not vaginal hysterectomy. Opportunistic salpingectomy or oophorectomy can be done during hysterectomy. It is important to be well informed about the relative benefits and harm of each approach to make the best informed choices for each woman needing hysterectomy for benign disease. Preferably, surgical approach of hysterectomy should be decided by women in discussion with surgeon, and it's moral responsibility of the surgeon to provide evidence-based, unbiased opinions. Also, the ACOG committee in 2017 June, it has also promoted vaginal hysterectomy as the approach of choice, and the same evidences has given rise to his committee opinion. Thank you.
And at the outset, I would like to thank the Amravati Society for allowing me this kind of a debate in their city with the person who is working here. Bhushan Baba, I know your embarrassment. You are the last minute entry. Being trained at Beams, you have to force to talk on NDVH. That is, it's pathetic now. Now, you must be aware of the recent scenario of CAA. The people are afraid of what they don't know, or that the ignorance leads to fear, and that fear leads to hatred, and hatred leads to kind of an opposite, which you are seeing in our country. And if you are not doing laparoscopic procedures nowadays, then you are not being with the flow. And let me tell you that within the next 10 years, everybody in this hall is forced to do some sort of a laparoscopy in their practice. It is a future, and you can't deny it. And after being last 31 years, when the hysterectomy has been done, first laparoscopic hysterectomy, this is a debate is slightly outdated. The topic would have been TLH versus robotic. Bhushan has rightly said it. And this is the most quoted article which says choosing the route of hysterectomy for benign disease. That is one of the very critical. And the last conclusion made by Bhushan is vaginal hysterectomy should be done whenever feasible. That is the problem. There are n number of problems. If there is a subpubic angle is less than 90, if there is a previous surgery or a previous infection leading to adhesions in the pouch of Douglas, low-lying cervical fibroid, bulky uterine pathologies, and the shape of the vagina. If the apex of the vagina is less than 3 centimeters, then the vaginal hysterectomy is difficult. And if there is a previous cesarean section, then it is always a problem. Although there are n number of surgeons in India, like Shirish said, they invented the space, but it is for any person, average gynecologist is difficult. And you can do opportunistic salpingectomy, maybe, can be. This is the kind of an ego that leads to a complication. And as I said, when there is an adhesions or there is a vaginal surgery appears not feasible, then the laparoscopy is the one. It itself clears the doubt in your mind. You can do any procedure with a laparoscopy. And the problem is why this has been negatively published. If you are going to do a laparoscopic hysterectomy only in difficult cases, or then you are going to have complications. So that is for sure. And similarly, if you cannot do a vaginal hysterectomy in that cases, so you might have a complication. So that is it. And second thing, the importance of learning curve, but that is also applicable to the NDVH also. The only point which is in favor of an NDVH is the time, but that is not very significant, 18 minutes. I'm saying majority of us doing laparoscopic hysterectomy in difficult cases. But now the 6 weeks, 8 weeks uterus, you are doing for an abnormal uterine bleeding and ovulatory dysfunction. The time would not be very difficult, rather more or the same. But apart from a time, these are the criteria where you can find that the laparoscopic hysterectomy is much superior. Now, he has mentioned about so many instruments, and he has mentioned is one of the instruments from his pocket, but he never mentioned a ligashore or a bipolar vessel sealer. Where is that, Bhushan? And now, if you say the investment is almost 20 lakhs for an average gynecologist, a training for it, let's say it's 3 to 5 lakhs, and the recurring investment like 3 or 4,000 for a Caesar or something like that. But why this has been negatively published by the Western data? Basically, they use disposable one. We are the one who are doing an Indian jugaad. We use a reusable instrument so that the cost can be drastically cut down. And with the same laparoscope, you can do another procedures so that you can earn more money. I'm a private practitioner. I'm here to earn the money, not to serve the society. And second thing, during your first year of a laparoscopic hysterectomy, the charges are comparable with an NDVH. But at the end of the 5 years, once you finish 30, 40, 50 cases, your charges get tripled up. So now with this instrument, he can go anywhere and do the practice. It is called, it's a very cheap surgery. Means he will do this kind of a surgery in 6,000, 8,000 or more less than 5,000. And I can say that in our city, we charge more than 60,000, 70,000 also, depending upon the merit of the case. You can reassess your videos, you can train your staff, you can train your residents, and with the laparoscopy, you can advertise in a paper. We are 200 gynecologists in my city, and only 7 setups can do. Blood loss is definitely lesser. Why that introduction of vessel sealer or bipolar is being introduced to the vaginal? It is because of this. And opportunistic salpingectomy can be done, but it's not feasible in majority of the patient, only 73%. And a tendency to not to do any kind of an adnexectomy is more with a vaginal hysterectomy. You can see it's only 3.2%. And additional pathology can be found while you are doing a laparoscopic, so that can be dealt similarly at that moment. Post-operative pain is much less because of a vessel, that nerve ending gets cauterized. That is why Purohit study was there, bipolar sealer was there. And febrile morbidity is much more this, and there was a traction, and this brings about a more pain. Vaginal patient cannot be discharged within 48 hours. Patient is done under regional anesthesia, catheter has to be kept for 12 hours, so its ambulation is delayed. So if you compare within a TLH, you can do it within 4 hours, 6 hours, 8 hours. We keep this patient for 2 days, 1 day for a patient and 1 day for us. Whenever the patient's relative visit that patient, we do get another 3 patients. And patient can really join the work very early. And one of the trickiest point being discussed that there are complications with laparoscopic to a lower urinary tract. And this is the study which has been given a major blame to the laparoscopy. They found that 6 ureteric injuries, but this is an evaluated study. But this study was reanalyzed by Donez et al., and he found that the surgery, the average surgery done by a gynecologist, only 21 surgeries in 4 years, and that is not enough to maintain your surgical skill. And it is that they have not followed the technique, they have not followed the proper this. It is because of inexperience of this. But same surgeon done both the study, and the complication rates are almost equal. So you cannot blame this. And your complication rates are slightly higher in the initial stage, but once you cross your learning curve or 30, 50 cases, then the complication rate is definitely low. This is the article I'm quoting. So these are the Indian studies also, and the Western studies also. And one of the very point I wish to, majority of the data is from Indian medical colleges, where the situation of laparoscopy is pathetic, teachers are outdated, anesthetists are non-cooperative, majority of the patients are malnourished, so they have done 2 or 3 vaginal home deliveries. So by the time you go for an NDVH, the uterus is almost at the introitus. So in that scenario, the NDVH it's not a case of an NDVH, it has to be a truly non-descent. It's a kind of a prolapse. So comparing Indian data with Western, it is not going to give you. So Bhushan, my friend, it is need of the hour. It's a need, and you should go for laparoscopic hysterectomy for the betterment of yourself also, and for the society also. Thank you very much.
And okay, but I would like to say that the vaginal route and the laparoscopic route is always a debate for everybody, and both these surgeries has a safer hand, I would like to say. Laparoscopy has a little bit of more learning curve, but with the good experience, this is also safe. So it is equally debatable topic for both of us.
But at the end, I would like to say, as a AMOGS take-home message, we were not judging here the persons, but we were judging board of the hysterectomy, most important. And believe me, even Narwadkar sir will do NDVH for the cases which are very simple and which can be done vaginally. And laparoscopy has upper hand and in a difficult situation. So rather this debate should end, and we should have a common verdict. Wherever possible, master both the skills. Patient is coming to you. Hey, you don't write here, I'm an NDVH surgeon, I'm laparoscopic surgeon, but master every skill of your gynec practice and then do it. So NDVH for uncomplicated, laparoscopy go hand in hand for complicated.